Hello, I'm Anne Duggan, Acting Chief Medical Officer at the Australian Commission on Safety and Quality in Healthcare. Welcome to the launch of the third and fourth degree perineal tears clinical care standard. I want to start by acknowledging the traditional owners and custodians on the lands on which we meet today and pay my respects to elders, past, present and emerging. I hope you enjoy this launch. I know that many of you are overseas guests, either burning the midnight oil or getting up very early. And I know in Australia, many people are trying to also do their clinical work. So we're recording this, and if you get called away, it will be up on our website very soon. Do tell your colleagues that couldn't make the launch that resource will be available. We want you to get the most out of the launch, so do post your questions throughout the session and we'll try to answer them in our discussion at the end. If you have any technical problems, then Redback's here to help you on 1800 733 416. It's now with great pleasure that I will hand over to Professor Villas Marshall, Chair of the Board, to officially launch the third and fourth degree perineal tears clinical care standard.
It is my great pleasure as Chair of the Board of the Australian Commission on Safety and Quality in Healthcare to welcome you to the launch of the third and fourth degree perineal tears clinical care standard. The Commission has a national role in leading improvements in healthcare safety and quality, and improving the appropriateness of care is a big part of this. In 2017, the Australian Atlas of Healthcare Variation recommended the Commission start to work to develop a clinical care standard to improve consistency in best practice care relating to third and fourth degree perineal tears. These tears can have both immediate and long-term physical and psychological impacts, such as pain, incontinence, reduced quality of life, and depression. The standard aims to reduce the risk of these type of tears and guide clinicians to offer appropriate treatment and ensure that women are involved in their care and treatment choices. I would like to acknowledge and thank the experts of our panel. We are lucky to have such a wealth of experts who can speak from their experience and able to inform women about reducing their risk of third and fourth degree tears and provide advice to ensure improved quality of care for women who experience these kinds of tears. So I'm pleased to officially launch the third and fourth degree perineal tears clinical care standard. I hope you learned from the presentations and panel discussion and that you come away with practical advice to help you deliver the best possible care to manage this important maternal risk.
Well, thank you to Professor Marshall. This is a great day for Australia. Before we discuss the standards with our panel, let's just consider for a moment more what this standard means for women. This is Jane. Jane's just given birth to Jack. It should be a great experience. But Jane has had a third degree perineal tear. And the issue for her is not just that it happened, but that she wasn't prepared. She was now being given quite confronting information and being asked to make decisions about her care at a time where she said her head was not in that space. It was quite clear to Jane that for her, having a conversation about the possibility of a perineal tear earlier on in her pregnancy, when she could digest it and ask questions, would have been much more empowering, and she would have felt much more supported and more confident about her birth. So there's great opportunity to improve the care for women during their pregnancy, so they are much more empowered if they're unlucky enough to have a severe perineal tear. Now, we know that perineal tears occur as the baby's head passes out the vaginal canal. It can stretch and tear the perineum. First and second degree tears are not uncommon, but they heal quickly with or without stitches and don't have any long-term complications. But third and fourth degree tears are much more significant tears that will tear the muscle around the anus, which controls our bowel function. And that can have long-term impacts on physical, psychological and sexual well-being. So we can't prevent third degree tears, but we can reduce them, and we can reduce the long-term consequences for women if they suffer them. Currently in Australia, 3 in every 100 women who give birth vaginally will experience a third or fourth degree tear. And for women giving birth vaginally for the first time, it's 5 in every 100 women. 1 in 20 first-time mothers, it's not an uncommon occurrence, but you can imagine that it's a very isolating experience for a woman when in a time when she may be much more vulnerable. In 2017, when we looked at perineal tears across Australia by where women lived, and we looked at third and fourth degree tears in particular, we found marked variation. As you can see by this map of Australia, where we've colour-coded according to the rate of tears for every vaginal birth, you can see there is marked difference. In some parts of the country, we were doing really well. We had only 6 women having a third or fourth degree tear for every 1,000 women in that area having a vaginal birth. But in other parts of the country, the rate was 12 times higher. So 71 women for every 1,000 women having a vaginal birth were experiencing a third or fourth degree tear. It is for that reason that we have undertaken and now published a clinical care standard, so that no matter where you live, you will have the best care. This standard has been done with the states and territories, clinicians, consumers, and everyone who has something to contribute has contributed to this work. The clinical care standard supports the delivery of evidence-based care. We know there is evidence out there about what makes the difference and what can reduce the likelihood of a severe tear. Its focus is on the high priority areas for quality improvement. It's not a clinical practice guideline that is comprehensive. Its aim is to reduce unwarranted variation so everyone has the lowest risk possible. Currently in Australia, our rate is above the OECD average, so we can improve and we can be more consistent. Perineal tears are one of the 16 agreed high priority hospital-acquired complications. So we have a system to focus on this. We have national safety and quality health service standards to protect the public from harm and improve quality of health in our health services. So we now have a standard we need to be looking at and ensuring that women are getting the best care. So just briefly, what are the quality statements? Well, quite clearly, we've recognised the importance of providing women with information. We want to reduce the risk of perineal tear occurring during pregnancy, by accidents during pregnancy and birth. And if it does occur, we want to improve the identification and the repair. And of course, we want to focus on ensuring that women who do suffer a tear are supported in their recovery. We've developed indicators that aren't mandatory, but allow you to track progress to ensure you are as good as you can be. Now, the standard is just a foundational document. We recognise you're all very busy, so we have developed a number of resources to help make it easier to make change where it's needed. We have 2 videos, one for our clinicians called Talking About Tears and one for consumers to understand perineal tears better. We have fact sheets and we have information sheets for consumers who want to know more or who have experienced a tear. And we will develop more resources. So please, after this session, go to our website and have a look, download whatever you want and go from there. Now, it is with great pleasure that I'd like to introduce our panel. First off, we have Associate Professor Emmanuel Karantanis. Emmanuel is an obstetrician and urogynecologist at St George here in Sydney. Emmanuel established one of the first clinics for women who had perineal tears and today still runs a clinic to support women who have had perineal problems. We have Professor Hannah Darlin. Hannah is a Professor of Midwifery and the Associate Dean at Western Sydney University. Hannah has had over 30 years' experience as a midwife and has a very extensive research career. Hannah was awarded a member of the Order of Australia for her services to midwifery, education, research and teaching. And we have Natalie McConaughey. Natalie is a physiotherapist at Dubbo. Natalie was instrumental in establishing a physio position for senior women and now also works in a group practice supporting women who have perineal problems to ensure they have perineal health. And of course we have Janelle Gullen. Janelle experienced a third-degree tear. It changed her focus and she's now an advocate who's focusing on improving consumer understanding, awareness, and improving the care of women who are undergoing vaginal birth. Janelle is an OT, so she's multi-talented. So let me start by asking you, Emmanuel, talking to women, not everyone's the same. Tell us about how you do it so that women have the best opportunity to have a vaginal birth if it is their choice, and one without problems.
Talking to women has not been a routine part of antenatal care when it comes to talking about perineal tearing. Unfortunately, it's been one of those difficult conversations. Often we are trying to reduce women's distress, and I think we can be sometimes to blame for not mentioning some of the things that are actually really important. And I think one of the beauties of the clinical care standard is it allows this conversation to come into the open. And finally, I think it helps us have some kind of framework for explaining to women what perineal tears are, what third and fourth degree perineal tears are, and how frequently they might occur, and what we can do to help them. And that there's often good care for these people, that treating these tears early can actually help decrease the chance of them having a substantial problem in the future.
Thanks, Emmanuel. Can I now ask you, Hannah, you've had, as I said, many years as a midwife. You've actually have your own style of doing it, but you've also seen other people have those conversations. Tell us from your perspective what makes a good conversation.
So I think the very first thing is that, women are smart. Women really care about what happens to them and their babies, and women want to be active participants in their care. And if we keep remembering that, we will realise the total burden is not on us, the providers, that this can be a partnership where we can have a shared responsibility and active role in making sure outcomes are really good. So we've got to be not frightened to say the hard stuff. I think midwives are pretty good at saying the hard stuff, but sometimes too busy and not realising how important it is. And having those conversations in ways that don't frighten women, but actually empower women. These things happen, they happen rarely, but when they happen, it's really important that we can do things to prevent it. We can make sure you're aware if it does happen, what the process will be, so that things aren't done in a rush without consent. In an acute moment, and women are often left in trauma from that. So I think the most important thing is to be respectful, to take time, to really see women as those intelligent participants in their care and share the burden of responsibility and participation with them. And I think this is really exciting because clinicians often take all of this on themselves and feel really, really terrible and how it's somehow all of their fault. But what we're saying in this is let's all work together to actively make sure women and babies have the best possible outcomes.
Janelle, can I ask your opinion, from your experience, what makes a good conversation? How should we move forward?
Thank you. I completely agree with what Hannah has shared, and I think the most important thing is that this conversation needs to come from a place of no fear. It is on the back of that framework of helping women make the decisions that are best for them and for their body and their baby, and knowing what their preferences would be if they are to experience a significant perineal tear as part of their birth, so that they're not feeling blindsided by that overwhelming decision that needs to be made, or uncertainty about what that might look like. I think it's really important that that conversation is personalised as well to that particular woman, her preferences, her particular situation, and making sure that that woman knows that there is support on the other side if she is to experience a perineal tear. Because for me, it wasn't experiencing that tear itself that was traumatic. It was the quality of the care, and at times lack of care, that I received afterwards, that made my recovery a whole lot more difficult than what it needed to be.
Natalie, you're one of those support people that Janelle mentioned. You specialise in seeing women who have had a perineal tear and who are recovering from it. And many of us don't understand what physio does, but so tell us about some of the work you do and how physios who will be among our audience can have those conversations with women who have suffered a perineal tear and have a good conversation.
Thanks, Anne. I think one of the things that, speaking from a postnatal rehab perspective, is that often I see two groups of women. And what I find is that I have women who come in who may not have been told about third and fourth degree tears. And the very first question that comes to me with that follow-up is, why did this happen to me? And, you know, why didn't anyone tell me that this could happen? And it's funny with that question that they ask me is that it's very quickly followed by a question around, well, was there anything I could do to help prevent this from happening? And so it's one of those scenarios where I find in those circumstances, the rehab process can be a little bit more tricky in the context that these women come in feeling helpless, they're angry, there's grief associated with the changes that have occurred, and there's a sense of frustration as to why didn't anyone tell me this could happen. That's very different to what I see in my group of women who come to see me and they've actually had good antenatal education around third and fourth degree tears. They've had good instruction around the things they can do to help prevent, but then they've also had really good instruction around postnatal rehabilitation. And what I find is that these women are very empowered. There's a sense of control that they have over their own body. They're really proactive. They get started really, really early in that rehab process. But our focus is around getting that early message of pelvic floor muscle training and being able to get that started nice and early, and in that postnatal period, working with women to help restore function after a third and fourth degree tear.
Thanks. It's very important to focus as much also on the positive, and to know that many women that you see have had a good experience in terms of great conversations beforehand.
Absolutely.
So, I think the Standard clearly is doing good work in reminding people of the importance of the conversation, and we've talked about the video there, which includes many of you talking about how to have those conversations. But of course, the other aspect is we also focused in the Standard on getting the evidence into practice. And Hannah, can I start with you? Tell me what you think are the important elements of the Standard that we really are going to get out there, that's going to make a difference, so that we can be telling people that there is a risk, but now with the Standard it is less than it was if you were in an area where there was a higher rate and changes have been made.
Yes, I think, knowledge is power, and this is really the focus of the standard. So we know that antenatally we should be talking to women. I don't think we need evidence to say that we should be respectful and all of those things. We have abundant evidence that when we don't get it right, it harms. So it's about having a conversation about what actually it is, what its incident is, and also not doom and gloom about everything to do with it. It's about things like perineal massage, which is actually quite empowering for women, and they feel that they can do something. We also have done research and shown that pelvic floor exercises antenatally can reduce the incidence. And when they come in to have that baby, and we would talk to them about this antenatally as well, so they were prepared, the importance of slowing the birth down. Now, when you're pushing a baby out of your vagina, and I've done it, there is a part of you that wants to just get that baby out and end what you're going through. But this is a critical stage, so slowing the birth of the baby down, and that's listening to your midwife or obstetrician's voice, and sometimes they will use their hands. The other thing that was the focus of my PhD, in fact I did the largest randomized controlled trial in the world, is warm compresses, and that is a warm cloth or pad put on the perineum as the baby's head is coming up. And we know that can reduce severe perineal trauma by half, but it also reduces pain, and women really love it. So to me, that's equally important. And the other evidence, of course, is if it does happen, that women are informed, that a very skilled person does the repair, that may be most probably advised to be in theatre where the lighting is good and a good job can be done, and that we don't have to remove babies from their mothers, because in our research we found a lot of women don't want to go to theatre because they want to stay with their babies. So we should be able to keep mothers and babies together, and then afterwards that we provide a follow-up plan which involves experts following them up, talking about the next birth, and making sure that if any issues rise, that we send them to our fabulous physios or colorectal surgeons or urogynecologists, so that there is a plan that this conversation continues with.
Thanks, Hannah. Emmanuel, many of the readers of the standard will see reference to instrumental birth. And as an obstetrician, can I ask you what your recommendations are and advice are in relation, and what's the issue in relation to instrumental birth? How do we do it well? What's your message to your colleagues here?
I think it's important to explain to women, as well as, and we don't really need to necessarily explain it to colleagues, but I think women need to understand that instrumental birth is sometimes necessary. And when instrumental birth takes place, it increases their chance of a 3rd or 4th degree tear. So it's important to be aware of that. There are obviously practices that we can use to try to minimize the chance of 3rd degrees tears and 4th degree tears in that instance. One of them being the use of a mediolateral episiotomy. Episiotomies don't have to necessarily, not all women want to consent to something like that if it occurred, but I really do think it's important to have that conversation antenatally, such that when a woman sees that she might be requiring an instrumental birth, and there are different reasons why sometimes women need it, she might have already thought about whether she would want to have an episiotomy in that situation, so that it doesn't become as a surprise to her when it does take place. And so that when we're consenting a woman for an instrumental birth, we're actually also consenting her for an episiotomy, potentially, if that's what she agrees to. I think that if we try to make that a routine part of instrumental birth, I think that can also help substantially decrease the incidence of 3rd and 4th degree tears. And I know that women are worried about episiotomy. I know it's a very unpopular idea, and sometimes I liken it to vaccination. In a way, it's a cruel thing, but it ends up trying to be a kind thing in those circumstances. And it's overall for the greater good for those women, essentially, in that episiotomies tend to heal really well. They tend to have no significant impacts for the vast majority of people who have them in terms of recovery or sexual function in the future. Sometimes they're a necessary evil.
Thanks, Emmanuel. Janelle, I just want to pick up on Hannah said about having your baby go with you to theatre. And I remember when we were developing the clinical care standard, we had a lot of discussion about that whole issue of separating the mother from her child, and whether that was actually leading to some women being much more fearful about the idea of going to theatre, and decisions not necessarily being made that would have otherwise been made, because, as Emmanuel points out, good lighting, good circumstance, environment to do a proper repair is terribly important. Can I just ask your opinion about that issue of how should we be pushing health services to really try to make sure that women are given that option?
I really believe that we should, and that was certainly part of my story. I was separated from my baby when I went to theatre. I was alone in recovery, and then once I got back to the ward at 4 a.m. in the morning, my husband was sent home. So there was a lot of separation and a lot of removal of those things that I really wanted around me at that time. And I think that could have quite simply be put in place some things that would have made that experience a whole lot more positive for me. And anything that we can do to keep mothers and babies together is really good policy and practice.
And I'm sure we are in many cases pushing at an open door, because so often in health people just haven't thought of it. So the idea of, well, that's a great idea, let's do it. Did I hear somebody want to add to that comment or that issue? Natalie, is there anything you wanted to add here in terms of going back to the issue of the clinical care standards and what you think is a real game changer from your perspective?
For sure. I think from my perspective, Anne, I think health professionals and patients who have ever experienced a 3rd or 4th degree tear absolutely acknowledge that importance of pelvic floor muscle training, the importance of the role that physio plays, and postnatal rehabilitation. I think what this clinical care standard does really, really nicely is actually has it outlined in it to be able to say this is what we need to be doing to ensure the care of women. I think that also one of the things that I really, really like about the clinical care standard is that it actually also acknowledges both the physical and emotional impact of the 3rd and 4th degree tear on women. And in that process of making that acknowledgement, we have a team, a multidisciplinary team working with women in that postnatal period to be able to try and sort of give them the best possible care. And I think that those couple of things are really, really important to get the best outcomes.
Can you tell us a bit more about your multidisciplinary team? Who's part of it?
We have a multidisciplinary team practice here in Dubbo. We have obstetricians, gynaes, we have midwives, there's myself as a physiotherapist. And what we do here is we actually work as a team both antenatally and in the postnatal period to be able to support women, to be able to give them the information that they need around 3rd and 4th degree tears, to give them the information antenatally to be able to support them with being able to be proactive and do all the things that they need to be doing to be able to help prevent it. But also that really early education around the postnatal rehab to be able to get them started early if they do happen to sustain a 3rd and 4th degree tear, and be able to support them in that process. And from my clinical experience, what I have found is that that journey of having gone through all of that with women and seeing that really positive outcome and how women have actually done really, really well when those measures have been taken to be able to ensure that they get good care.
So that's a great example of a rural, but a large rural area doing it really well. I might just bring in Emmanuel, if I may, and ask Emmanuel to tell us about his clinic at St George's, which is very much in metropolitan Sydney. Emmanuel.
Well, it's not. My clinic is in a way similar to Natalie's. It's inside the hospital. So it's part of the hospital service. And I believe that it's really important to try and stay within the hospital service so that there's a continuity for the women who suffer the third and fourth degree tears, that the notes are there. The women know that we have that information about their birth. When women have a third or fourth degree tear, we have a routine system of our physiotherapists visiting those women, even on the ward, arranging follow-up appointments with the clinic and support services. And then inside the actual clinic, the first port of call is our physiotherapist, who then collates some of the history and listens to the woman and tries to identify some of the more important factors that are important for her, whether it's a physical issue, whether they have fecal incontinence problem, whether they have an emotional problem, a sexual problem. And we try to, sometimes they have all of them, and they often need to debrief at that moment. We need to go over what happened at the birth. They sometimes have some really important questions to ask. Within our department, we also have a nurse who has a midwifery background, and we have registrars, and we have a colorectal surgeon and an anorectal physiology nurse as well. And I think we're a really happy team. We are very well motivated to try to help these women as much as possible. And part of our mission is not just helping, it's also about training our hospital, trying to liaise with our birth unit all the time, and trying to teach our registrars different skills, repairing, for example. So we have an overall mission of trying to not just treat women, but also trying to prevent these occurrences as much as possible.
It sounds like both you and Natalie would be very happy to have conversations with people who want to set up or see whether they can change their setup to be more effective. Exchanging ideas is such a great way of moving forward. I want to ask Janelle, because Janelle, you've experienced a tear. Tell me from your perspective, some of your thoughts about multidisciplinary clinics and what are the bits that really you think made a difference for you and could make a difference and will make a difference for others.
I think the multidisciplinary team is a really important part of supporting that recovery for a mother or a birthing person who's experienced a tear. The physical aspect of that, those pelvic floor exercises, the information that the colorectal surgeons and so forth can provide is useful. But for me, equally important was actually work that addressed that scar tissue, that looked at my mental health, my emotional well-being, things that explored the impact of those roles, relationships, identity, the way that I felt about my body, the way that impacted the way I connected with my baby as well. All of those things, we need to make sure that women are getting access to that type of support as well. We just can't separate that mind and that body, and all of those parts need to be considered as a whole so that women can come out the other side with a really good quality of life, feeling really positive about their experience.
It's fantastic. Hannah, you've obviously, with all that research you've done and all the literature you've read, you know a lot about this area and the evidence. Can I bring you in on it to make a comment?
Yeah, and I actually want to pick up on what everyone said.
Yeah.
And Natalie and Emmanuel, I think, manifest the best way to possibly approach this, which is that multidisciplinary approach, which is getting the best of all of our skills and putting the woman in the centre and making sure that whatever happens, that we support her as an individual with our various skills, because none of us can contain all the skills required in this issue. So that, I think, would be such a fundamental thing. The second thing is something Emmanuel mentioned, which was continuity. And we do know that, you know, women who have continuity, and the research one of my PhD students undertook, we interviewed women across Australia who had severe perineal trauma. And we had some women who'd had continuity who had some pretty significant effects and yet really didn't feel traumatized and felt listened to, heard, put into the system, supported, respected. We had women who had no symptoms and were utterly devastated. And continuity of care was a fundamental part of that. So having a provider who provides, builds up a relationship, builds up trust, gives you time for ongoing conversations. Then that voice at the birth is familiar and trusted, and so you'll listen when the midwife or the obstetrician says slowing down the birth. And then the follow-up is so critical because this person knows your story. Now, we can't have that for every woman at the moment, though we're working hard to make sure every woman does have a midwife they know. So we have to embed continuity into the systems that we've got so that women don't fall through the gaps of this. So I think that's absolutely critical. And then, what Janelle was talking about is the importance of being heard, the importance of being able to ask questions, of having other issues than us clinicians may think are important. We tend to, because we deal with so many people, get very focused on clinical tasks. But a woman's not focused on clinical tasks. A woman's focused on birthing a baby. And the biggest organ involved in having a baby is the brain. And we often, sadly, neglect our attention to psychology, communication, support, relationships. So I hope that through this, we bring multidisciplinary teams to the forefront. I hope we really value continuity, and where it isn't there, we embed it. And I hope we listen to women and realise that having a baby is far more than a physical event. It's a psychological, spiritual, social event, a phenomenal life transition for a woman. And we need to think broader when we address these, what we often think are clinical issues.
Thank you. I want to now get down to some practical components now, because I imagine a lot of our audience out there want to do the best and are listening and know that there are things that they could tweak. So let's, for a moment, I'm going to go around the room and ask you, and I'm going to start with you, Natalie. If you are giving advice to someone to make where to start, and advice to a physio who's involved in this area, what are some practical tips as to what they can do after they've left this launch and go back to the day job and sit down, have 5 minutes to think about what can I do differently? What would your suggestions be?
Oh, wow. I think some of my suggestions around what we can do differently, I think is the first one would be absolutely embracing our multidisciplinary team. I think that certainly the opportunity to be able to work with one another rather than in isolation, and being able to sort of, I think from a physio perspective, we are very focused on pelvic floor dysfunction, and I think that being able to put that into the context of the entire birth experience is a really important thing. So being able to have open discussions with our midwives and our obstetricians around our concerns antenatally and postnatally, and being able to work within that framework.
I think that sounds very sensible. And I think one of the good things about the clinical care standard is we've got a common source of information to have a conversation about how to work in a multidisciplinary manner.
Absolutely.
Can I ask, sorry?
That's okay.
Emmanuel, what's your advice to keen clinicians who really want to get started? We've got the clinical care standard now. They're probably functioning very well, but they want to be the best. What's your, if you're busy, you've got 1,000 things to do, what's your way in terms of getting started? What do you think's the way forward?
I think with the clinical care standard, I think one of the things that it has brought out is a clearer understanding that as doctors, we can't just treat people in terms of their issues, physical issues. We have to try and think about the person who's connected to their child and their birth experience. And I think one of the important things is that we have to spend a little bit more time. It's actually a very difficult thing to talk to registrars about this, because they actually have a really busy clinics, Even this morning in the birth unit, I'm the consultant for the birth unit at St George today. We talked about how we could do this, and because they're quite distressed as well about this conversation. It's that we're all trying to learn through it as well, and we started to think about how we might be able to introduce these ideas into our clinics for our women. They started to talk about maybe TV, little video presentations or information while they're waiting in the waiting room. I would actually like to advise my colleagues, my consultant colleagues, and all registrars and anyone in any clinic just to use, for example, the clinical care standard information sheet that we just start handing them out to each person, and pick a week in your antenatal week that becomes that reminder for you. So for me, it's 34 weeks or 36 weeks. I just make sure that that's when I give my patients information, and I hand them something, and that's when they do it. It's a bit like making sure they have a glucose tolerance test at 28 weeks. It's just routine, and it doesn't get forgotten. So that's a really good, simple step to try to make one of those particular weeks in the third trimester the week when we have that perineal conversation.
Fantastic, fantastic. Hannah, what are your thoughts about how, in a busy midwifery practice where there's so much to do, how do you get started if you really want to review the practice and think about making some changes?
So just to reiterate what I said before, continuity of care obviously is the ideal way to do this, but we don't all have it. So I agree with Emmanuel about setting a time. We have a whole lot of triggers along our clinical pathway of when we give women information or tests, but I'd also put caution around it. We can't just hand them a brochure, and we've got plenty of research that shows us that's pretty useless unless we have a conversation and answer women's questions. So if a brochure gets given, there needs to be a conversation, and then let's talk about it next visit once you've had a read. So I think that's a really critical thing. I just want to make another point, which I think is really important, and that is that, and I think Emmanuel brought this up as well, we feel really bad when a woman has a severe perineal tear. We really do. And in the last few years, there's been this sort of increasing almost name and blame around it. And I've noticed I run an exercise, which I've run for a few years, where I ask midwives and doctors to name their top fear when it comes to childbirth. And I've noticed that third and fourth degree tear has started to slip in, when previously it was what you would imagine, the death of a baby and a mother. So I want to just emphasize that this is about working together respectfully and being kind to each other. This should not be about naming and blaming. And, this isn't yet another stick with which clinicians need to be hit with, but this is about us all working together to support each other, to put the woman at the center, and to do the best we can. And sometimes third and fourth degree tears will happen, and we need to not take that stuff to heart and become even more interventive as a result, which is not a good outcome as well. And we need to be able to understand the pathways and the processes and be kind to each other. So I agree with points and milestones. I think the relationship's absolutely critical, and I think we need to have good relationships and respect with each other so that we don't end up practicing defensively as a result, but we become very woman-centered in our approach and share that responsibility and share that pathway with women.
Sounds good. I want to, while I've got you, ask you the very important question, and I'll ask some of our other panellists. We are at risk, I would think, that if we don't have the conversations appropriately, that women will choose to have a caesarean where they don't want a caesarean. They want the vaginal delivery. They want the baby to have the gut microbiome to be from the mother's vagina, and so that they're healthy throughout life. How I can see now that we've got a clinical care standard that is really going to be part of the national standards and drive down the rates of third and fourth degree perineal tears. But how do we get that conversation happening now as we make progress?
It's such an important point, Anne. There are risks with cesarean section, and we know that if a woman can have a vaginal birth, on the whole, that is a better thing for her to have. It's better for her, it's better for her baby. And yes, there are some disadvantages with vaginal birth and there are some disadvantages with cesarean section. But when you weigh it all up, when you do not have significant risk factors, cesarean adds significant risks. So it's really important that we keep that in balance. I think it's very sad that unfortunately the discourse around this has become politicized and has become a battle of how bad is vaginal birth and how good is cesarean section. It's a very misinformed discourse. It's actually the majority of women want a vaginal birth. The majority of women want to have a birth that leaves them and their baby in the best condition. The majority of women want to have consented, informed, respectful care. So let's do that. And let's have those conversations and answer those questions, but be very, very clear. This is not saying that having a cesarean section is a better way out, because it's not for the majority of women.
Thank you, Hannah. Can I bring you in on this, Emmanuel?
Yes, I was glad you did, because I wanted to say something about that, following on from Hannah, because I fully agree. I believe that most women want a vaginal birth, and actually, even those who have had a 3rd and 4th degree tear would like to have a vaginal birth in the future, for the vast majority. But I think people sometimes we worry that when we start to talk about perineal tearing, that we're going to turn women away from a vaginal birth and have a cesarean. I've not found that in my research. We recently, a few years ago, published a paper where we gave women information about perineal tearing and 3rd degree tears and episiotomies, and we found that it actually helped decrease their anxiety. It did not turn them over towards having a cesarean. And I'd like to just reassure all our medical and midwifery colleagues about that.
Thanks, Emmanuel. Janelle, I have to ask you your opinion on this subject, because you are someone who's experienced this, and I don't know whether you've thought about more children or what, but you must even philosophically have a view.
Yeah, no, it is a really good point. And for me personally, a vaginal birth was what I wanted. And I agree with Hannah and Emmanuel's comments that information is empowering. It isn't off-putting, especially when it's presented in a way that really acknowledges that there are a lot of risks associated with cesarean sections as well. So I have gone on to have another baby after my tear, and that was quite an interesting experience, because in contrary to the way that Hannah and Emmanuel talk about this, I was basically told that a cesarean section was my only option, and quite outwardly ridiculed for even considering a vaginal birth. But I did my own research, and I decided that that was the best option for me and my baby, and I did birth another baby with barely a graze. But I think having that information really customized to that woman or that birthing person, really recognizing what their values and their priorities are, and giving them information that isn't just a blanket brochure or a blanket policy, but helping them explore what actually happened in a birth, what their particular risk factors might be, and helping them land on a decision that they feel really confident about and that they feel really empowered about.
Thanks, Janelle. Consumer confidence is terribly important in this, and one of the things that I suspect that consumers don't know enough about is the national standards, which, as a second standard, it talks about partnering with consumers. And I, a few minutes ago, asked people about practical things you can do. I think it's probably important for people like yourself to be confident that part of the national standards requires health services to look at the variation they have in the care they provide, and to provide the data when there is variation to clinicians, so that clinicians can then work again, adopt a standard such as this clinical care standard and improve care, so that we have nationwide much less variation and good practice. I imagine for a consumer, thinking about that and thinking about the fact that health service should be providing information, that's a very reassuring situation for women, getting information, knowing how well your health service functions, and that it's actually also working to allow you to have the decision, to have the choice that you wanted to make and have that discussion in a way with your clinical expert who is open to your preferences. Did you find that, Jadelle, that it was important to be able to find a clinician who was going to listen to your concerns, listen to your preferences, and allow you to talk through what you wanted?
I think that was directed to me, and most certainly that was one of the key things, finding a team and practitioners that really respected my point of view and were happy to have those conversations with me. That certainly made a really big difference as I worked towards that subsequent birth.
Fantastic. So collecting the data is so important to know how we're travelling. We're getting short of time, so I wanted to take one of our questions from the audience, if I may, and ask you, Natalie, somebody, I don't know whether a physio or not, has asked, does every physio is trained in managing and helping women who have had a perineal tear? And if not, if you are a rural or the only physio or the physio responsible for it, how do you get upskilled? Can you just give us a bit of advice there?
For sure. Absolutely. And the Australian Physiotherapy Association has a pathway that they've developed to be able to train and upskill physiotherapists in this area. And within that, there's online training, and then there's also face-to-face as well. And so for physios who are working in a rural area where it's difficult for them to be able to travel, this is one option of training that they can also do through the APA's clinical pathways. Also around that discussion around services to rural areas, I think one of the purposes of the clinical care standard is to reduce unwarranted clinical variations. And the thing is Australia is a really big place, and geographically there are women who are at a disadvantage if they're either rural or remote, and these service provisions that are outlined in the clinical care standard aren't available in their particular area. And so I think one of the things it's really important to acknowledge is that I think people need a support person locally that is in health. So whether or not that's a nurse practitioner, a GP, or it might be a physiotherapist who might not necessarily have the experience, expertise, or training in this particular area. And what we can do is that I've been a physio in a rural area my whole career, and I have had a very small time remotely. And having that support person that they can sit with face-to-face and have that discussion around how they're going, but then make really good use of our technology. We have the availability of telehealth, and I think it's really important. These clinical care standards are there for us to be able to outline those standards, but then how do we use that technology to be able to deliver that standard into those areas? And I think one of the things that we have, or I have used, is that hubs and spokes model of care, where someone in a larger centre with the expertise around third and fourth degree tears and the experience can actually help guide whoever the clinician is in that rural setting to be able to have that online telehealth session with all three of them to be able to sort of deliver care. It's really unrealistic to expect a woman with third and fourth degree tears who's experiencing pain and discomfort with their tear to sit in a car for 6 hours and be able to drive to a larger centre with a newborn baby in the car, maybe with or without a support person there. And so we need to come up with practical ways of how we get around that and be able to deliver the services into these areas.
Fantastic. COVID has not been all bad. I think we have learnt a lot about telehealth, and we've all got a lot better. So it's fantastic, because I think maternity distance has been so tough for many areas.
Yes.
We're coming to the end of our time, but I do want to go back just to get some final take-homes from everyone. So while I've got you online, Natalie, what's the one take-home for you?
I would really encourage women to educate themselves, be able to ask the questions and those hard questions of health professionals, educate around what you can do to help prevent a third and fourth degree tear. Educate yourself around what the things that you need to do in that postnatal period to be able to help, with your recovery. And that would probably be one of the things that I'd be strongly encouraging them to do. Just to add to the discussion before around the vaginal birth and cesarean birth, I have actually found that through really good care in that postnatal period and really working with women to try and sort of strengthen up the anal sphincter and be able to work towards good outcomes for them. There's been times where I have had the experience that women have gone on to have a second vaginal birth, and what I have found is that they actually have had really good outcomes with a second vaginal birth. So I think it's sort of our job is to be able to support women to be able to make decisions for their health of themselves and their babies.
Thanks. And I'm being advised that we're running out of time, so I'm going to just ask Janelle to give her take home, if you don't mind, Emmanuel and Hannah.
Yeah, no, thank you. I think it is so important that we get this information to women so that they can make choices as they prepare for their births. Because let's be honest, some of the things that can help reduce that chance of having a significant tear are pretty simple for that woman, that birthing person and her support team to be carrying out. And for mothers who do experience a significant tear, I really want them to know that they're not broken. I think there is a lot of messages out there that you are broken after an injury like this. There is so much support out there, and you can find amazing quality of life doing all the everyday things that you're needing and wanting to do when you receive this quality care that is outlined in the standard.
Thank you. And I know that all clinicians out there amongst our audience are and keen to do the right thing. I know they're very busy. I just want to point out that we've put those resources up there on our website, and when you're thinking about looking at your service, seeing where the gaps are, remember that we've also got a user guide for looking at clinical variation, which is on our website as well, and which will help you start that process. If there are other resources that you think we should be developing, do let us know. It's now time, unfortunately, for me to close. I'd like to thank our panel very much for all the wise words they've given. I'd like to thank the working party that helped develop the clinical care standard. And I'd particularly like to thank you, the audience, who demonstrated your interest and your commitment, and who will now go away and start to look at your services to see whether there's anything you can do to make it even better for women. Do let your colleagues know that this session will be video conference and videoed and will be put up on our website. As you close, we will give you a survey which is brief, but we really would like your feedback on this session, and we always wanted to do better. And on that note, I will end and thank you very much for your time, and all the best at trying to ensure that no matter where you live across Australia, if you are having a vaginal birth, your likelihood of a third or fourth degree tear will be lower than the OECD average. It will be the best it possibly can be. Thank you.